We're going super high tech today. Okay, friends, welcome back to another episode of very high-tech interaction here today. We're going to start by being very simple today. So as you can see, right here we have a very simple QRS complex. Let's identify the P, Q, R, S, and T waves. So the first wave right here is our P wave, and then we have our Q. And if you know your alphabet, you just follow it along. So it's P, Q, R, S, and T wave. Now, as I said, the two most important waves are your T wave and your R wave. The R wave is most important because the scanner has to be able to put little tags on each R wave. Now, as I mentioned, the R wave is the most important. The reason being is the scanner has to have a way of identifying where each cardiac cycle essentially begins. And in the cardiac CT world, we've made the R wave to be our starting point and also our ending point of the cardiac cycle. Now, having said that, we also need to know where our T wave lives. That'll come in very handy and very important for you when you get into scanning in systole and with millisecond timing. We'll talk more about that in a future video. For today, we just want to understand that we have our P wave, Q wave, there's our R, S, and T. Now, notice I've put these little tags on here just like your CT scanner were to be tagging. This would ultimately be how you want your scanner to look. You always want your tags to be tagging on the R wave. Now, where it is super important is when you're setting up your patient and bringing those arms up before you put your ECG leads on, because the ECG placement is going to matter. Plus, the different types of leads that you use also matter, and we will cover that in a future video as well. So for today, understand where everything lives. So this is then your R wave right here. That is the first R wave, then we have another R wave, and so on. So we call this the R to R cycle, or the cardiac cycle. In CT, we sometimes will call it R to R. Now, your R to R has to have some sort of numerical value to it. And in cardiac CT, which is different from all other areas of CT, is in this cardiac cycle, we have the ability to plant radiation where we want. Well, the scanner has to have some sort of way to know what numerical values would be assigned to that. The easiest way has always been percentage, because we always start with 0%. And if we end anything, we end it in 100%. So now we have 0 to 100. Now, if you follow this line of thought, you will have 0 to 100% for each phase. But this now starts over. This now becomes 0% and goes up to the 100%. And same thing, 0%, 100%. So if, for instance, you said, I want to scan at the 70% mark for every beat, that would be roughly here. We're just going to guess where that would be, and we would deliver our radiation right here in the 70% cycle. If your scanner has the ability to prospectively scan, it will guess on where it's going to plant that radiation based off of so many beats prior. Some scanners, you have the ability nowadays to actually change that. Most scanners I see everywhere from 3 to 10 beats prior can be selected and set. 5 is most often used that I have seen. However, I have also seen different facilities and different providers set different numbers for that prospective look. So it's prospectively guessing beat, beat, beat. Okay, I'm guessing the next beat's going to be there, so we're going to scan. Now, if your scanner can do all in one heartbeat, that means cover all the tissue in one beat, you only get it in the phase you choose In this case, we're saying it's about 70%. And you get the entire heart in that 170%. That is based off the physics of your scanner and how much coverage you can cover per rotation. This is where you really need to know your scanner, and you really need to understand what you have for capabilities. Now, if your scanner can only cover so much tissue, it may have to then scan on multiple beats. So it may have to get 70% here. And if we draw a crude heart, and let's just draw a heart today, a really bad heart, but there's a heart. If you have to acquire all your data in multiple different beats, each beat will be a section of heart. So you would have one beat here, and then you're going to cover more here, and you have to cover more tissue here, and you may even have to cover one more here, depending on your scanner. You'll have more beats, less beats. It's also depending on the length and size of the heart. But how that works is the computer takes this data set here, and that will be the top portion of your heart here. And so this will refer to the top. Then you'll have another beat with another scan. That'll be your next one, and then your next one, and then your final one. So each one of these will go to a section of images, and then your system will put it all together. However, if you have a system that can do it all in one beat, let's pretend this is our single beat, then this would cover all the tissue of the entire heart all in one beat cycle. Again, if this is prospective scanning, what's happening here is, again, it's guessing. It's looking at beats, looking at beats, looking at beats, it's guessing, and boom, it's going to scan. However, there's also something called retrospective scanning, and we will again dive more into that in an upcoming video. What I want you to gather today is that we have the R wave, it must be tagged well, and it is based off of percentage 0 to 100. Now there is one more way of scanning, and that's called millisecond scanning. So this is called percentage scanning here. There's also something called millisecond scanning. How that works is your first R wave is 0 milliseconds. Now, depending on the rate, the heartbeat rate, so depending on how fast the heart is running or pumping, will depend on how long of a timed cycle this will be. Regardless, if your percentage scanning is always 0 to 100, 0 to 100, 0 to 100, why this all matters is when you get into arrhythmias in the future and you start doing high or low heart rates with arrhythmias, that's where you really have to know when to apply millisecond scanning and even systolic scanning. But for today, let's understand that we need quality R tags. It is 0% to 100% if you're in phase scanning or reconstructions, and then in millisecond scanning, which you can millisecond scan and millisecond reconstruct, depending on your machine's physics. And we're just going to pretend this is going up to 800 today, so 800 milliseconds. So this is how that works. Now, if you have a steady heart rate where the heart rate never changes, your milliseconds on the end R wave will always stay the same. However, when your heart rate gets very erratic and gets very sporadic, it can get all over the place. So for instance, this could be down here 0 milliseconds. The first beat could be 800 milliseconds. The next beat, if it were shorter here, could be, and again this starts over, just like it does with percentage, each beat starts, ends, starts, ends. It could be 400 milliseconds, depending on how fast the beats change. Then this next one could be like 1200 milliseconds. Why is this important? Well, when you're in millisecond scanning, you can see that there's a great big difference in time. And as I said, we will tackle millisecond scanning versus percentage scanning on our next video. But for today, all I want you to know is this is what your PQRST looks like. R is most important. T is your second most important. Again, will come in handy for systolic scanning and millisecond scanning. Prospective scanning is when the scanner looks at so many beats, guesses, and then scans. Retrospective is that it looks at the beat and then scans exactly where you want it. That's the simplified version. All right, guys, this can be a lot. I get it. And we're going to take this slow. If you have any questions, you can always shoot it my way. Take care, and we will see you soon.